Hello everyone. Warm greetings from team Learn from the Legends. I am Dr. VC Manoj. Hearty welcome to the 18th webinar in our series and the second one on birth asphyxia and neuroprotection. Today I have great pleasure in welcoming a novel innovator to our series. I happened to hear his talk in one of the NBS webinar series and I must admit I was thoroughly impressed. Friends, let us welcome the faculty for today's lecture, Dr. Gabriel Variane, founder of Protecting Brains and Saving Futures and Medical Director of Neuro NICU at Sao Paulo, Brazil. Hearty welcome, Dr. Gabriel. I also have great pleasure in welcoming two legends who will be moderating today's session. Dr. Ranjan Pejavar, President of NNF India 2021 and Dr. Sandeep Kadam, Senior Consultant from Pune, India. Hearty welcome, sirs. And now, respected delegates, it is my proud privilege to welcome you all for today's session. We are truly humbled by the massive support and participation that you have all shown for our Learn from the Legends webinar series. In fact, we have more than 2,500 attendees from 65 countries who are watching this session live in Zoom or YouTube, or who subsequently watch the sessions in our YouTube channel in the next 24 hours. We are so humbled by your presence and thank you so much, dear friends, for your support. Now, without wasting any more time, may I request the moderators to carry on with today's session. Thank you.
Good evening, everybody. It is my great pleasure to be here on the occasion of the webinar Learn from the Legends. I should commend the efforts of NNF Kerala and the neonatology chapter, Manoj and team specifically, for carrying on this webinar series punctually without fail and attracting a vast thousands of delegates to watch the webinar across the world. It's a great achievement, and I must say the webinar itself is slowly becoming a legend. Now, today's topic is a very fascinating one. At the same time, I'm sure it will be interesting. At the same time, it's very important one. It's using technologies to protect brains in resource-limited countries. What can be more relevant to us? We have the technology in India. We have problems with HIE. Even today, 20% of the neonatal deaths are due to HIE. And also, we have a lot of morbidity, which is remaining. So it is very important for us to look after the brains of the living ones and also to minimize the damage to the brain. What Dr. Gabriel has done is, in addition to the research which goes on in therapeutic hypothermia and various other aspects of brain damage and brain protection, he has gone one step ahead and he has innovated ideas to monitor the brains and the neuroprotection strategies in a large number of hospitals using modern technology. He's in collaboration with Microsoft. He's using artificial intelligence and remote and real-time assistance he's providing to all these hospitals. That is really great. He's not only a scientist and a researcher, he's gone one step behind in implementing whatever has come out of that science and research. So without much ado, I will hand over the mic to my co-chairperson, Dr. Sandeep Kadam from Pune, and he will formally introduce Dr. Gabriel Variane and also make his comments.
Over to you. Thank you, sir. Thank you very much, sir. It's an honor to introduce Professor Gabriel Variane. He's a medical director at the Neurological NICU at Sao Paulo, Brazil. He's a staff consultant. Most important, he's a founder of Protecting Brain and Saving Future. As rightly said by Dr. Ranjan Pejavar, sir, we have a lot of problems of HI. We have technology, but more important, using that technology in our perspective, especially for the lower middle income countries, and most important, using the technology not only helps save our babies, but it's very important to have intact survival. And I'm sure with Dr. Gabriel, who has done his graduation from Brazil at Sao Paulo, he's also started an organization. He's using technology. His area of research has been neuroprotection in lower middle income countries. He's been collaborating with the Imperial College at London, and we also has done a lot of collaborative research with from the Stanford University in United States. So I'm sure with his vast experience in learning and teaching, and he has been involved in focus in spreading a knowledge in various countries through various webinars and seminars. I'm sure at the end of this lecture we are going to have enriched minds, and we can use this in our day-to-day practice to save babies and have more and more intact survival. So without wasting much time, over to you, sir. Thank you very much. And we would also request all the delegates to write their questions in the QA box, so that at the end of this lecture, we'll take those questions one by one. So please write your questions in the question answer session, so that we can cover these questions at the end of the lecture. And I'm sure with many participants, it's going to be an interactive session. So we look forward to having more and more questions from all of you. Over to you, sir.
Well, in first place, I would like to say thank you so much for the organizing committee, and to Dr. Ranjan and Dr. Sandeep for the kind introduction. And again, I feel definitely honored to be part of this fantastic webinar conference series. And again, very, very honored to be talking about a topic that I particularly think it's really, really important, that how can we add technology to help us to take care of these babies at high risk for brain injury in our scenario. So I will start sharing my screen. Please let me know if you can see this right now. And I will just move to full. Just a sec. Can you see my screen?
Yeah, it's fine.
Okay. Now just a sec. There you go. And wow. So the topic I'm going to talk today is using technology to protecting brains in resource-limited countries. And just before starting our talk, actually, I would like to have a very, very quick poll with you on only 2 questions that I would like to set a baseline and actually understand how our scenario from the delegates from this webinar is different or similar from the one I live here in Brazil. So I'll gently ask you to fill and answer the poll, only 2 questions. There you go. So the first question would be asking, so how does your center provide therapeutic hypothermia for neonates with perinatal asphyxia and moderate or severe HIE? And I would like you to answer if yes, you are providing therapeutic hypothermia and you use a servo-controlled thermal mattress, or yes, you're providing therapeutic hypothermia, but you're doing passive cooling with ice gel packs or turning the heated crib off, or no, you're not providing therapeutic hypothermia, but you can transfer your baby with HIE to a center that provides cooling, or no, you're not able to provide cooling in your center and neither being able to transfer these infants. And please feel free to answer. So there you go. So the majority, actually 49% of the respondents are providing therapeutic hypothermia, and they're using a servo-controlled thermal mattress. Also, you're gonna see this is a bit different from what we have here in Brazil. And around 19% here are you providing therapeutic hypothermia, but using passive cooling or just turning the heated crib off. Okay, so we can move to the next question, which would gonna be about brain monitoring methodologies. So what you're doing in your centers. The next question would be, does your service have the possibility of providing continuous brain monitoring with EEG or AEG, amplitude integrated EEG? And only 3 options. So no, you do not count with the possibility of performing EEG or AEG in your center, even intermittently, or no, you can perform conventional EEG, but not continuously during the entire cooling period, or yes, you have the possibility of providing continuous brain monitoring for AEG or EEG in your center. So please feel free to answer the poll, and soon we can see the results. So around 1/3 for each part, right? But only 38% actually can provide continuous brain monitoring during the cooling period during this first 72 hours of life. Okay, so this set up a nice baseline. I'm gonna share you the data from what we have here in Brazil, and moreover, I truly think we can discuss again how can we use technology to protect the brains of our little babies at high risk for brain injury. So let's start. So just as disclosure, I'm the founder and currently work as director of Protecting Brains and Saving Futures organization, which I'm gonna show to you during this presentation. So the objectives of this talk includes describing unique healthcare challenges for infants at high risk for brain injury in developing world. We're going to list the challenge to implementation of these neuroprotective strategies in low-middle income countries, and we're going to describe the benefits and results of a telemedicine model for assistance of infants at high risk. So just starting with an neonatology overview, we know, oh, there you go. Just a sec. Just so just starting with an neonatology overview, we know we face important reduction in mortality rates, which is really good, but we have a high number of infants who survive with risk of neurological impairment. So looking at the world scenario and talking this presentation specifically about infants with HIE, we know that epidemiological studies brings us to us that we have in the world over 1 million infants with HIE per year. And from those, over 230,000 infants with HIE will develop important neurological impairment every single year. And I always like to think if this is actually a representative number, because you know we're talking worldwide. But if you think this is one of the largest soccer stadiums in the world and have around 100,000 people here, if you multiply this number by 2.3, and remember we have this number of infants that will develop important neurological impairment every single year, this is actually a very, very important number. So this is not only the social impact, what about the economic burden of this population? This is also truly, truly important. Here we have a study done in the United States and being done by RTI and CDC, and they were estimating the direct and indirect costs of this population. And we are talking, and when we talk about infants and babies that will develop neurological impairment, the indirect costs are really, really important. And especially we're talking about productive loss here for 10, 20, 30 years of their lives. So the productive loss is really, really important. And results from this study being done in US, so they have, they estimated the lifetime cost with only American population from children with development disabilities, they are over $67 billion. So this is a very important cost. We have done a similar study here in Brazil. So we are estimating that infants with severe disability may have a 150 time increase in cost among 20 years of life. And we know the economic burden of this population is truly, truly important, again, worldwide. So in conclusion, we know that high risk situations for brain injury implying high mortality rates, high morbidity, and high cost. And by looking into this, we know that today we face an evolution in the focus of the NICU care, that now we want to improve neurological and neurodevelopmental outcomes. So we want to reduce the mortality, but with good neurological and neurodevelopmental outcomes, and this makes lots of sense. And the first question would be, okay, but how does neonatal care vary across the developed and developing world? Because, you know, we may face completely different scenarios, and of course, we may face different levels of assistance. So I invite you, all of you, to look under this scenario under the lens of a new perspective. And in this presentation, we are going to talk about the healthcare situation in developing countries, a new approach, collaboration with international studies, and potential benefits. So starting with healthcare situation in developing countries. So here we have the world map, and we could look at this into country income groups. If you look in for high income groups, we know that usually we have good quality data, good quality prenatal care, investment in new technologies, strategies to the newborn care, lower rates of neonatal sepsis, mortality, and neurological impairment. But what about the low middle income countries? It's the same scenario, and we know it's not the same scenario. So usually we have lack of good quality data, a wide range of resources offer, incredible variability of protocols and neonatal assistance, poor prenatal care, higher rates of sepsis, mortality, and neurological impairment. Talking specifically about HIE, the incidence in high-income countries of HIE ranges from 1 to 2 per 1,000 live births. And when we come to low-middle-income countries, the incidence is much, much higher. Actually, if you're talking about birth asphyxia, it could range from 4.6 per 1,000 Cape Town to 26 per 1,000 Nigeria. Case fatality rates may be 40% or even higher. And actually, because the limited availability of this data, the figures are likely to underestimate the real proportion of mortality and morbidity due to birth asphyxia in these countries. Here, if you're looking at another study and looking at the regional burden of neonatal deaths and encephalopathy outcomes for babies affected by intrapartum events, actually you can see that the large number of the population worldwide comes from the low middle income countries, and we know this very well. So just by understanding this scenario, it would be really interesting to think on a new approach. So how can we deal with the situation? And in first glance, we could think, okay, so how high-income countries are dealing with the situation, trying to reduce the chances of these infants develop neurological impairment. And now we have these strategies that include brain focus and NICU care, and we're gonna talk specifically about neuroprotection. But talking about brain focus and NICU care, actually there is an increased use in clinical practice of multiple methods for brain assessment in order to improve the neurological and neurodevelopmental outcomes. And here a very strong concept that's is growing over the entire world is the neurological neonatal ICU concept. This is a picture from universities in the United States, and they teach us some principles on pillars of this concept that includes continuous brain monitoring, neuroassessment, neuroimaging, and neuroprotection. And talking specifically about neuroprotection, and if you're talking about HIE, of course, brings therapeutic hypothermia to the discussion. And we know that, especially in high-income countries, this is being applied as a standard of care for infants with moderate or severe HIE on a large scale by different projects and programs over the world. In 2015, I got the privilege to visit University of Cambridge in UK and to know this project, which is the BBOP, or Baby Brain Protection, that in 2012 implemented on a large scale that infants in the east of England that would have birth asphyxia and moderate to severe HIE would receive proper cooling in the centers. And of course, this brings us to the next question. So what about the implementation and efficacy of these strategies in low middle income countries? And there is some data, important data about this. And here is a meta-analysis from Dr. Sorrenteil's group, where he was looking at the effect of cooling on neonatal mortality. And he found this group actually found that cooling therapy was not associated with significant reduction in neonatal mortality in low middle income countries. And the big question here is why? What exactly happened? Because we know that actually cooling should work for this population. So the apparent lack of treatment effect might be due to the heterogeneity and poor quality of these included studies in this meta-analysis, inefficiency of the low technology cooling devices, lack of optimal neonatal intensive care, sedation, ventilatory support, overuse of oxygen, or could even be due to the intrinsic difference in the with high rates of perinatal infection, obstructed labor, intrauterine growth retardation, and maternal malnutrition. So there are some important points that might explain exactly the apparent lack of the treatment. By understanding this scenario worldwide, I would like you to invite to understand the scenario I live here, the country I live in Brazil, and explain what exactly we face in our reality here. So just to talk briefly about Brazil, you know, in Brazil, we are a country that we like soccer a lot. Actually, we love soccer, and we have the largest carnival in the world, and we are actually have many beautiful places to visit, and definitely I invite you to come to Brazil when it's feasible too. But it's really a nice country to come. But we're actually much more than this. So Brazil, we have a population of over 200 million people. We have 26 different states, and we talk specifically in neonatology. In Brazil, we have around 3 million live births a year. From those, we have estimated around 20,000 infants with HIE per year. This brings us the number 2 babies with HIE per hour. In our situation, and even looking further into the overview of our scenario here in Brazil. So we have over 8,000 neonatal care beds. We have lack of resources on a varied scale, and we have a huge, and I mean we have a huge variability in clinical practice across the country. So talking about heterogeneity of care, we have level 3 neonatal intensive care units, you know, that might have everything you want. So centers with large amount of resources, equipment, specialized multidisciplinary team, fetal surgery, advanced imaging, again, everything you want. But we have, on the other hand, centers level 3 units with centers with lack of resources, equipment, lack of this multidisciplinary approach, or any kind of advanced imaging, and actually don't have a robust neonatal transport network. So it actually depends where you are born. And what about the cooling practice in Brazil by understanding the scenario we live? So we published in 2018 a survey that we're looking was a survey related to the assessment. So how people were dealing with babies with HIE and therapeutic hypothermia practices across the country. And this survey included over 1,000 participants from most of states in Brazil. So what were the results? And that I told you, they are a bit differently from the pool we just got. So for all respondents, actually we found that 62% of professionals reported using therapeutic hypothermia, which in a first glance is quite good. But reasons for not providing would include lack of adequate equipment, knowledge, training with this intervention. From these professionals that do not provide cooling, 94% stated either not having a referral center to provide cooling or unable to perform the transfer within the first 6 hours of life. So again, it actually depends where the baby is born, if he will receive or not this treatment. But talking specifically about the professionals that responded that they were providing cooling to the population, we found that only 26% were using a servo-controlled system, so the vast majority would do passive cooling or use of ice gel packs for assessment of encephalopathy, and this is something that I think might be some troublesome. So from the centers that were doing cooling, only 58% reported using Sarnat neurological score, 8% reported using a different neurological score, and 22% reported not using any neurological score. So exactly, we're not sure how they are indicating these babies for cooling or not. And what is really troublesome is that from the ones that were using neurological score, only 20% had received any type of training for that. So again, how we're choosing and selecting our babies for the therapy is something that really worries us. And talking specifically now about brain monitoring and imaging. So you understand the number of centers that were doing cooling, who are using the proper equipment, who is doing the neurological assessment adequately. And what about brain monitoring and imaging? So we found that only 12% of respondents who provide therapeutic hypothermia had EEG or EEG readily available, and only 4% had access to neurophysiology services and continuous video EEG. And talking about imaging, only 19% would be able to perform the MRI, and 43% actually could provide an MRI in an outside location, but it was really not clear whether this was being done or not routinely for these babies. And a good sign here, 72% of centers had access to neurology consultation, which is quite good. Quite good for this population. And the last part of the survey, we asked for follow-up. So how these babies after discharge are being conducted. So follow-up was unavailable at almost half of centers. And when available, was established multidisciplinary follow-up program was presented on only 21% of the centers. So again, as conclusion, we found that results from this large survey demonstrate that therapeutic hypothermia has been implemented in Brazil, but with significant heterogeneity in most aspects of its management. And actually, for final results, we have a huge variability in the criteria for therapeutic hypothermia indication, management, method of cooling and monitoring, and even inappropriate follow-up. So actually, by understanding this scenario a couple years ago, I remember that by that time, I thought that I got a brilliant idea by that time, you know. I came directly to the government and just asked them, wow, you know, we just have these very nice examples from high-income countries. And, you know, why should we not start a large project to implement adequate care for infants at high risk in our country? You know, people are doing this, we should do this. And I was really, really excited by that time. And when I came to the government, they just said, oh, Gabriel, we are not high income country, don't have money, forget about it. We are not, you know, we are not, we don't have money for this. And you know, no money, no honey, so sorry, there is no way we could implement this in Brazil right now. And of course, by that time I was quite frustrated, but then we started to think about possibilities. And okay, so we have across the world different programs that implemented this on a large scale. We live in Brazil, which is a continental country, a very large one here in South America. We don't have much money, that's true. But maybe technology might help us to overcome these barriers. So this is where we started thinking about a new project around 4 years ago, which is the PBSF project, or Protecting Brains and Saving Futures project, which is a low-cost, self-sustainable project that united a group of specialists that you want to teach, enable, implement protocols of neuroprotection, early diagnosis in infants at high risk for brain injury on a large scale in our country. So we are a private organization. We want to make a united effort with hospitals, physicians, industry, healthcare insurance, Ministry of Health, everyone, put everyone together for the same goal. So as I told you, we started PBSF project around 4 years ago. And actually for this project, we have two main pillars. The first one would be teaching and implementation of methodologies and protocols. And the second one would be our intelligence project. And we are gonna run through this presentation for both pillars. So starting with the first one. So which were the initial aims for PBSF projects? So we wanted to promote longitudinal training and use of standard international validated protocols. And I may say that training and education is a really, really important part of this project. Implementation of structured therapeutic hypothermia across a large number of centers, implementation of brain monitoring, and this may include video EEG, AEG, NIRS for infants at high risk, again, on a large scale. And the big thing here, and I'm gonna repeat this word many times during this presentation, we want to promote homogeneity of care across the country. This is really, really important in this project also, homogeneity of care. So the big question, or the next question here, okay, how could we do this in a country, you know, where we don't have many resources? And we truly think, and we've thought about this 4 years ago, that by using information technology, a telemedicine system, and developing what we call the CSI, or Central of Surveillance Intelligence, it's a monitoring center, we could achieve this. So the CSI is actually a monitoring center that can connect to any NICU across the entire country, and now even internationally. And of course, when we do this, we can have a database that can connect physicians, research centers, universities, industry itself. But this approach has several advantages that must not be ignored. So The first one would be centralizing data from different and distant populations. We have a highly specialized live assistance, 24 hours by 7, high level of teaching, longitudinal training. It's different from doing, you know, I'm gonna do a course and implement a protocol. No, I do a course, implement a protocol, and I follow each patient that is included in that protocol. So this is really interesting. Intensive support to the clinical staff, again, 24 hours by 7, you have a specialized team aiding the NICU and the physician at the bedside. This facilitates the implementation of methodologies and protocols in different centers in a lower cost model, which is really important. And this allows, again, homogeneity of care between centers with different amount of resources, which is really, really nice. So this is just a video that I'm trying to explain to you how this works. So we have here a baby being monitored in a remote center. All the information goes directly to a cloud system, into Microsoft Azure. And we have a monitoring center and a remote team that 24 by 7 is responsible for reviewing this exam, providing feedback, discussing the clinical case, and again, promoting homogeneity of care. So just to make it more visual to you, so here we have a baby being monitored in a city called Belém, in the Pará state of Brazil. This is in the north of Brazil. So he's receiving cooling, he's receiving brain monitoring. Here, the information travels over 2,000 kilometers and comes directly to our monitoring center here in São Paulo, Brazil. So, and everything, of course, stays, this information stays on a cloud servers, centralized in a very secure way. So talking about IT and security itself, so we have a physical environment, which we have the cloud systems, the monitoring center, all information comes to a high availability data center. We have local data protection, a central security management console. All data is uploaded, encrypted, and all remote access, of course, is always authenticated, and we have a central remote access management. Again, it's very important, so we have a very robust security system to deal with this data from these babies traveling through the internet. So talking about this and this introduction about PBSF project, it's time to share with you some of our experience. So again, we started this project 4 years ago, and when we started this, we started with 3 different centers in the city of São Paulo. And right now we have experienced this with over 30 different hospitals across the entire country. We have centers in all regions of Brazil right now. And again, from this baby being monitoring, we have remote access by the CSI 24 by 7, and all information is stored in a central and secure database. Moving forward, again, so we do implement brain monitoring, and another piece of information, another piece of this project that's really, really important again, is promoting homogeneity of care. So we use standard protocols and a very robust education program. And from the protocols that we implement, 2 are really, really important. And the first one would include the cooling indication, and we follow the NICHD criteria and management for these babies. And we have brain monitoring indications, and I'm gonna share to you what we're doing right now. So we have this protocol that's adapted from Lucille Paget Children's Hospital from NeuroNICU at Stanford. So there are 14 indications that we're doing brain monitoring for these babies. So babies that have HIE and are receiving cooling, babies with seizures, the preterm population, especially if they have complications such as IVH or shock, congenital heart disease, severe IVH or hydrocephalus, inhibit errors of metabolism, metabolic disease, CNS malformations, central nervous system infections, severe sepsis, hemodynamic instability, ventilatory instability, hemodynamic significant PDA, depending on the case, babies with mild HIE that are not receiving cooling, and babies with severe hyperbilirubinemia, and babies under ECMO. So this is our protocol that we implement across the centers that we are working. And again, a very important part of this project is education. So we built a course that we call NeuroNICU, from theory to clinical practice. In the last 3 years, we have provided 17 different NICU courses, which are actually hands-on workshops, and we trained over 850 people. Last year, we did a very, very large, and we're really, really proud to made one of the largest, or maybe the largest conference to talk specifically about HIV being done in Latin America, that we counted with over 1,000 people and with 9 different international speakers. This was a very, very nice experience. And talking about neonatal and online neonatal conferences, we're really proud that this year in Brazil, we've done a conference for over 15,000 attendings, and again, using technology to spread education, which is exactly what we're doing right now, which is really, really nice, which is a lesson that this specific year of 2020 teaches us. But again, moving back to our talk and presentation, remember, this project stays because we want to do standardization of care and clinical practice guidelines between different centers through the use of telemedicine. And again, I told you I'm gonna repeat this a lot in this presentation. You want to promote homogeneity of care. And take a look. It's really, really nice that when we use this model, we can implement the same protocols of brain-field assistance from the largest private NICU group here in Brazil, with over 200 NICU beds, with over 30,000 live births per year, to very small public NICU in distant places. And we have here a region in Brazil called Baixada Santista region that had the highest infant mortality and birth asphyxia rates over São Paulo state. And there were some small cities in this region that would have up to 24 child deaths for 1,000 live births in some cities. And up to 2016, no center would provide cooling or brain monitoring or anything related to this. And up to 2018, 3 different centers were associated to PBSF program and implemented the similar protocols and brain-focused assistance from the wealthiest NICU centers of the country. And what was really, really nice, that we faced very important reduction in infant mortality rates in the past 3 years in this region. And of course, this is teamwork, but we like to think that this project actually also helped to make the difference in the region. And just to show you some of our data, here we have data from July 2017 to June 2020. So this is a 3-year period from the centers and babies we monitored. So from that period, we monitored over 3,000 babies with over 200,000 hours of monitoring. And by that time, we experienced this in 28 different hospitals. And we found had almost 35,000 connections between CSI team and the local staff. And when we started, we were monitoring 15 babies per month. And in June, we were monitoring around 130 babies by that month. So just looking at overall data from this population, and from all babies we monitored, we found seizures in 24% of them by providing the brain monitoring. And the most relevant monitoring indications included suspected seizures, HIE, but not cooled babies, HIE that received cooling, previously treated seizures, hemodynamic and ventilatory instability, babies with complex congenital heart disease, and sepsis. And from that population, so seizures by monitoring indications, this is a question that people bring me all the time. There are 4 most relevant groups that I would like to share to you. So babies with HIE that received cooling, 37% of them received had seizures in this cohort. From infants, preterm population with severe IVH or shock, 23% of them got seizures. Babies that were diagnosed previously with seizures and then started doing the brain monitoring, 35% of them had new seizures under the EEG monitoring, and babies with congenital heart disease, 25% of them presented seizures, especially in the post-operative period. And for seizures classification, from the babies we diagnosed seizures by providing brain monitoring, 74% of them only were diagnosed with subclinical seizures, and 14% of them had clinical or subclinical seizures. And this is data from literature. Actually, we know that most of seizures are actually subclinical, and they're really difficult to monitor if you're not providing brain monitor. And looking at the number of anticonvulsants per infant, of course, the ones that presented seizures, Only one drug, which is of course the phenobarbital, was able to stop seizures and control seizures in only 57% of these infants. So around 43% of babies with seizures needed at least 2 anticonvulsants to control the seizures they were having. And this brings us to the possibility and ability to doing some sub-analysis. And again, looking now for only infants with HIE, we had in this cohort treated with therapeutic hypothermia over 500 infants. 37% of them presented seizures, as we just showed to you. And most of them, as also we know from the literature, comes in the first day of life. And some of them, around 80%, came into the rewarming period in this population. We're talking about the PBSF project, and we're talking about the first pillar, which would be teaching and implementation of protocols. And now we're moving to the second pillar, which is our intelligence project. And I always like to look at the rationale for this. And when, we're talking about telecommunication, you can use a simple device just as this and connect anywhere in the world lively, just again, as we're doing right now. And when we come to the NICU, we have all these fancy monitors that provide information continuously to us. But in the end of the day, we are just looking into a piece of information that every 2 hours, for instance, someone will just add back there a piece of the information. Even if you're doing using electronic records, most of the time you're just recording a piece of information from this population. So what do we think about the proposal and evolution of this model? And we truly think that through, intelligent monitoring center, we might provide remote assistant, correlate information in the NICU, and allow better understanding of the physiology. And this actually may aid to create new treatment algorithms in the future. So we truly believe in the importance of correlating different findings into the NICU, and you might use technology to do this. So just to explain what was our learning experience. So when we started 4 years ago, when we started the PBSF project, while we were doing in our monitoring center, all we could do, it would be the remote EEG, and most of times would be 2 or 3 channel EEG plus amplitude integrated EEG. And right now what we can do, we are adding more pieces of this information. And one that is really nice is now that in the same platform, we can add the NIRS information, near infrared spectroscopy, which is cerebral oximetry and somatic oximetry. So here, when we're doing brain monitoring remotely, you can look at the brain function by the EEG and also brain oxygenation, which is really nice. And combining this information might be really, really useful. I'm just gonna show to you one simple case. So this is a term baby intubated due to meconial aspiration, pulmonary hypertension, ventilatory instability, and sepsis. And in the 3rd day of life, he got this AEG. We remember that doing EEG in the NICU is much more than just for seizure screening. It's actually, you can look at brain function, and you can clearly see that something is really wrong happened here to this baby in this time period. The background activity was really, really depressed in acute form. And when we add another piece of information, I can clearly see that here in the blue line, the cerebral oxygenation goes down. And when the cerebral oxygenation goes down, we can see a clearly depression on the EEG, and it gets better. And when the cerebral oxygenation gets better, the EEG recovers as well. And it's really nice to understand the correlation between those parameters. And what happened to this baby? He got, obstruction in the tube, and that was why this happened. But ideally we would not only correlate the brain monitoring findings, but actually all kind of findings and vital signs from this baby. So not only putting EEG and NIRS together, but why not putting SpO2, heart rate, temperature, blood pressure, everything together in the same platform. So now we are working a system similar like this, that here we can see the temperature, the pulse oximetry, the cerebral oximetry, heart rate, the EEG, and so on. And here's just a case discussion. So how putting this together might allow us to understand or better understand the physiology. So here we have a preterm baby with 33 weeks, third day of life. He was diagnosed with meningitis. And here is the trend line monitor for him from all vital signs and brain monitoring. So here we have temperature, the NIRS findings, the pulse oximetry findings, and heart rate. And this is a 38-hour window. So the trace is very compressed. Take a look at the correlation. So here, when I have a decrease in pulse oximetry, I have an increase in heart rate and a decrease also in NIRS. And if you look at this, this repeats many times during the trace, and this makes sense. You know, you have a decrease in pulse oximetry, you have repercussion of this on NIRS and also on heart rate. This makes sense. But take a look in the end, in the last curve here. So here we have a sustained decrease on cerebral saturation. We have moments of important hypoxia, but it recovers sometimes. And we have moments that the heart rate goes down, then it goes up, then it goes into the middle of the way. So something different is happening in this part. And when we add another piece of information at the EEG, we can clearly see, and this was confirmed by raw EEG, this baby went on status. And when he went on status, probably the consumption of oxygen in the brain was higher, and that was why the cerebral sats went lower. And you know, and you could see all this the saturations and the heart rate going upside and down. But again, I think the beauty of this kind of system is that we can better understanding what's happening to the physiology of this baby. So this is our new operational concept. So now we have here the baby being monitored at the hospital. We collect data from the vital signs monitoring, from the EEG, from NIRS to integrate the data. We send the data to a cloud system, and then our team at the monitoring center can better understand the physiology and give feedback to the team. So what's up next? And you know that what would be really interesting for our system and from our scenario, we would like to create accurate alarm systems. And there are many groups and many nice publications on this already. But what we were working is with a system that's sending mail to the neuromonitoring team, you know, for automated seizure detection or EEG pattern changes. And again, when we're doing brain monitoring, it's not only for seizure detection, it's also looking at brain function. And take a look at this case. We have a term infant, Apgar scores of 2, 4, 5, 7. The blood gas has important acidosis. This baby underwent cooling. He got seizures within the first day of life, but with 24 hours of life, this baby got this background activity, would call for continuous normal voltage, which is really, really good for this infant. And actually the prognosis right here was quite good. But then received an alert. This was 4:50 a.m. and the new EEG pattern was found like HISO from Isoelectric, and this is the exactly time point at 4:50 a.m. in the morning. So this raised a red alert. So we called the center and said, oh, something's happened to this baby. And I recall the physician told, no, is the baby having a seizure? And I told them, oh, actually worse than this. The background activity is very, very depressed. Please, you know, go see this baby. And he said, oh, you know, the heart rate is quite normal. Blood pressure is normal. Pulse oximetry is definitely normal. And you know, he's not moving, but you know, this baby has HIE, maybe it's because of that. And I recall, no, there is something really acute happening to this baby. And the physician at the bedside went to do an echo and he found a cardiac tamponade. And we know that cardiac tamponade, if underdiagnosed, might lead this baby to a cardiac arrest and new brain injury or even death. And for this baby, actually here, the physician was doing the Marfan puncture, and this baby actually never got a cardiac arrest. Here's the moment that we have the depression on the brain activity, and in less than 1 hour, it was already recovering, which is really good. And the outcome for this baby was quite good. So he was discharged with 10 days of life, normal MRI when he reached home with 7 months, 9 months of age, here with 1 year of age. The baby was already walking and also, you know, shopping, which is really good for the economy of the country as well. And again, this is, I think this is a good case, a good example of how reaching earlier alarming might make a huge difference on the evolution of a baby. And this brings the discussion to a new level because you know what's the evolution for this. Of course, we would like to analyze this correlation between all monitoring parameters. We can work with big data analysis from this national database, machine learning system, creation of new risk scores, promoting earlier and more accurate diagnosis of brain injury. All this, there are many possibilities for us to doing this. And I would just like to show the system we are developing right now. So this is the view from the physician and the monitoring center. Here's the space view of all centers that we're monitoring in Brazil. This center is called Santa Casa University. And when we are doing the brain monitoring for this baby, actually now we can look not only on brain monitoring findings, but we can look at the AG, at blood pressure, pulse oximetry, the NIRS findings, heart rate. So we put all information together and we can classify, just for the video a little bit, and we can classify all these babies that are being monitoring automatically according to their risk, you know, looking at heart rate, pulse oximetry, again, all vital signs and brain monitoring findings. And in the end of the day, all this information comes directly to the dynamic dashboard so we can understand what's happening to all the population. And we're really proud to collaborate nowadays with Microsoft themselves, because we're working on new cloud architecture and AI project to improve our assistance capabilities. So in the end of the day, the CSI, or our Center of Surveillance Intelligence, is much more than just a monitoring center. It's actually a project of medicine, engineering, information technology that has a specialized team that runs a server web in order to get real-time information from the associated centers, that provides remote assistance, filtering, storage, classification, and protection of this information, working with capability of correlation, this is stored information creation of what we call neural networks, and in order to promote knowledge generation, clinical research. So in the end of the day, the CSI is a project of diagnostic assistance, information, and knowledge generation. So, Gabriel, so I understand the work you're doing, but you know, when PBSF works in a hospital, what exactly you do? So we work as an advanced telemedicine model in order to aid and structure the neuronic concept across different centers. How? By implementing the technology protocols and all required methodologies, promoting initial and longitudinal training. Again, education is so important in this project, associated with monthly video conference with all associated centers, implementation of the CSI, connect 24/7, allowing the use of standard protocols, case discussion, remote brain monitoring, promoting data storage and analysis of NICU results, and working as a highly specialized assistance model with homogeneity of protocols, clinical care, ensuring the optimization of methodologies and resources. And which is really nice, it's much easier and faster applicability if you're comparing doing this one by one center across the entire country. Just very briefly, and we're ending our presentation, for future directions, we want to have now a closer neurophysiology approach and implementation of remote video in a larger number of centers with amplified telemedicine assistance, considering giving consultations for neurology, genetics, cardiology, infectious disease team, neuroradiology, development, care, and follow-up and assessment is really important and really a barrier for this project. So what we want to do for following this population, so throughout the use of technology, again, we are planning to have longitudinal connections to every single infant family who was assisted by PBSF, with our own follow-up assessment PBS team, collaboration with local follow-up clinics, and all data again from follow-up will be stored in single database. That's the idea. So as future directions, right now we have experience in over 30 hospitals in Brazil, but our goal in the next few years is just to reach at least 100 hospitals across the country. And of course, this brings us to another level of discussion, and our goal is also to promote an international brain monitoring network. And this is feasible. Of course, there are barriers, but this is definitely feasible. So ending this new approach, the way we are using technology here in Brazil to aid this population at high risk for brain injury, I would like also to share with you collaboration with international studies. And this is a study that we are really proud to be part of. This is the PREVENT study, or prevention of epilepsy by reducing neonatal encephalopathy. The chief investigator is Dr. Surin Teo. The trial sponsor is Imperial College London, and the study is funded by NIH. So the rationale of this study that is being conducted in India right now is that 50 to 70 million people, there are 50 to 70 million people with epilepsy worldwide. We have estimated 12 million people with epilepsy in India. The incidence of epilepsy in low middle income countries is 2 or 3 times higher than high income countries. The perinatal brain insults accounted for the largest attributed fraction of pediatric and adult epilepsy in these countries, and programs to improve perinatal care in low middle income countries may prevent a substantial proportion of epilepsy. So what does this study propose? We have 4 intrapartum interventions that consists in constant birth companion, fetal surveillance during active labor, labor management by e-partogram, brain-oriented early newborn care with resuscitation, and the assessment of newborn outcomes includes EEG and MRI. And for PBS collaboration, what we're doing in this project, we created an advanced telemedicine model and an EEG cloud-based system to the PREVENT study. And the number of estimated monitoring infants in this study is going to be 2,000. So what exactly happened? So Dr. Surin Teo asked me from Brazil to implement this system directly in India. So we are running this study in 3 important centers in Bangalore, Calicut, and Hubli. And providing EEG monitoring in the centers, and all this information can be assessed by the remote research team, which includes Dr. Surin Teo, Dr. Ronit Presler, and that are located in London, UK. And all this information, you know, from the local hospitals comes to the cloud, and this can be accessed by the remote research team. So this is what we're doing in this study. We're providing this architecture. And just to show to you how does this work, this infrastructure and security is like this brief video. So we have information coming from the 3 hospitals. We have an XM database replication, the PBSF central database, and we can have feedback and reports from the remote research team. And very briefly, the data security precautions. All local devices have security systems that provide malware protection, management, updates. Everything's controlled by a central cloud. All locations have equipment data backup capabilities with advanced technology duplication, encryption, compression, optimizing, again, all the data transmission bandwidth, and ensuring this additional layer of security. And communication between the local equipment and the central servers is always done with encrypted data, protecting the privacy of transmitted data. And this is a picture of part of this team. This is a very large study from the PREVENT team. Again, I'm very honored to be part of this group. So to end our presentation, I would just like to remember some potential benefits of preventing or children to develop neurological impairment. And of course, the first one is the economic benefit. We know that by reducing the number of patients with neurological impairment, there will also be a significantly reducing the direct and indirect costs of this population. This is very important when we want to convince people to invest in this kind of methodologies. For the hospital itself, it adds technology, intelligence, and a remote team to aid in the treatment for neonates at high risk. And of course, the largest benefit ever is what we think is that we have sometimes the opportunity of changing life histories, allowing more infants to fulfill their physical and cognitive potential. And this is really, really important. And so in conclusion, strategies to reduce the chance of brain injury, implying reduction of mortality, morbidity, and cost. And this is truly, truly important. And just for acknowledgement, I would like to say thank you to all my team. This is actually part of our team is growing quite fast, that work on daily basis, providing and allowing this project to grow. And there is a line, there's a phrase that I always like to think and bring into my talks, that we think that preventing neurological impairment is actually a very, very big challenge, and not just challenge for Brazil, but actually worldwide. So this is a line from Anton Lake, former executive director from UNICEF, where he says, somewhere a child's been told he cannot play because he cannot walk, or another, she cannot learn because she cannot see. Well, that boy deserves a chance to play. And all we, that's the most true, all we benefit when that grow and all children can read, learn, and contribute. Well, the path forward will be challenging. It's not easy to prevent neurological impairment, but children do not accept unnecessary limits. Neither should we. And then we end our presentation. And just as one last announcement, I would like to say that we are conducting together with Dr. Reni Bashir, Dr. Guilherme Santana, who presented early in this conference series, and also Dr. Topon Austin from Cambridge. We are running a survey called Practice Related to the Management of Infants with HIE. And Dr. Reni Bashir will soon send you a message similar to this, which is a really brief and fast survey that, similar from what we published here from the data of Brazil, we would like to understand what are the practices being conducted in India. And again, thank you so much. It's really honored to be here with you today.
Thank you. Thank you, Dr. Gabriel Variane. That was a fascinating lecture. And it's awesome that you are doing such good work. And as I mentioned earlier, you have gone beyond research. You have helped in implementation of the knowledge and benefits of the research and translated it into various hospitals getting the benefit of that. I don't know whether I have missed while you were speaking, what is the health system of Brazil? Is it like in England, fully state-owned healthcare, or is it private and public healthcare? What is the healthcare system?
So it's public and private as well. It's, I may say, around 50% of population goes to the public centers and 50% would stay with the private care.
Okay.
So it's, yeah.
Because the reason I asked that was Dr. Dennis Khalili had asked, how is the funding for this beautiful project? That was his question.
Yeah, so that's a very, very important question. And actually, I think I'm gonna share, I have a question that, people ask us all the time. So, how this was economically feasible, what is the funding? And actually what we're doing to the hospital, we are providing a service. So we charge the hospitals or the public centers we try to charge them for the brain monitoring hours, for instance. So we provide this service, and in the end of the day, there is a report, and we try, to discuss with the hospital this importance, and then we charge it. So we had initial people who invested in this idea, but in the end of the day, the project is self-sustainable because we are able to charge for this kind of assistance.
And what percentage of your hospitals are purely private, and what percentage of your hospitals which are under your program are, purely government or public?
Yeah, that's a very good question, and thank you so much. So actually, again, half. So 50% of all these infants that we monitored, over 3,000, around 50% come directly from the public centers and 50% from the private. So what you understand is, again, that this is a kind of assistance, this is a kind of model that could be implemented in both public and private centers. And again, I think the huge issue here, and the most important step on implementing and actually convincing people to, to adopting this kind of assistance in their center, and doesn't matter if it's private or public, it's actually showing them that, by investing in preventing neurological impairment in children, they are not losing money. Actually, they are, winning lots of money, because again, this is economically feasible, because the economic burden of this population is terrible. It's terrible. So the cost effectiveness of this kind of approach is important. Yeah.
So there's a lot of health education you have done, and you are continuing to do about these things. Okay, I'll now hand over the mic to my co-chairperson, Dr. Sandeep Kadam. Can you take over and proceed, Dr. Sandeep?
Yeah, Dr. Gabriel, it was an excellent presentation, and you have shown how we could use technology to the benefit of our babies, especially in neonatal neurology, because we want to save babies, but we want them to have intact survival. And there are a few questions which have come up. Does EEG done in first 6 hours in a child who is in stage 2 HI exhibit changes to warrant giving therapeutic hypothermia?
Yeah. So yes. So what we do for all centers that we work, so we implemented this equipment at the hospital. So the equipment is always in the hospital. So we train all the staff, the nursing and medical staff, to start using the EEG monitoring prior to 6 hours of life if the babies, you know, they have HIE. So this is actually really important because this brings us more information, you know, looking at the background activity, or maybe at seizures themselves, the baby needs to be receive cooling, yes or not. So this is very useful and a very important part of the protocol to start the brain monitoring prior 6 hours of life.
Did your organization also provide equipments like cooling machine or amplitude integrated EEG to peripheral centers?
Yes, so I think I'll, just a sec, I think I will share a slide. So what actually happens? Yeah, so yes, again, this comes to the question how this is economically feasible. And what is really interesting, what we do, we implement the equipment here in Brazil. We implement all the equipment, the EEG monitoring, and if the hospital wants also the cooling equipment, and we charge nothing for the hospital by this, because actually what we try to do is, for instance, a 5-year contract, and we dilute the cost of this equipment over a 5-year period. Why we do this? Because we want the project to be economically feasible for the hospital itself. So if you come to a hospital, but then you know this equipment are quite expensive. If they need to buy this, they don't want to start the projects. So what we try to do is to dilute this in many, many different years. So we do implement the equipment in the centers.
The next question is, your presentation was excellent and innovative, and applying IT to healthcare and integrating into NICU and therapeutic hypothermia. I'm sure this is a comment, and I'm sure this can be implemented in our country if government supports. There's one more comment that it was a fantastic presentation. Kindly asking how centers from lower middle income countries can key into this laudable initiative. I'm in a neonatology unit of Lagos, Nigeria, and most centers in Nigeria do not cool. The emphasis has been on neonatal resuscitation training to prevent HI rather than treat. So your comments on this?
Yeah. So in first place, thank you so much for the comment. And again, I think we could connect in first place, and further discuss maybe how could we show you and how could, explain exactly what we have done here in Brazil, and maybe find even, possibilities for collaboration. Because again, we are talking about brain monitoring, we are talking about cooling, but the main pillar of all these projects is promoting homogeneity of care and using telemedicine to, have and to deliver specialized assistance to remote centers. And I may say we have already some international projects collaborating in, could be both education and even helping their centers to structure something similar in their own country, or even connected to PBSF itself. So we are definitely open for discussion. And again, I would love to collaborate the way we can. Yeah, but it's definitely feasible. And you can use this kind of system, again, for providing resuscitation, but also for starting a cooling project and brain monitoring project in some centers as well. So I think this is quite the beauty of it. Yeah.
Ranjan sir, would you like to ask a few questions? So there's one more question. How was the neurodevelopmental follow-up done in those babies in Brazil, whether it was done at your center or in the peripheral units?
Yeah, so that's an excellent question. And what happens again for this very moment, is that we still rely, so we're working in 30 different centers. So we still rely in each center capability of promoting this follow-up. And this will differ a lot from each center to another one. So we have few centers that have, this multidisciplinary approach and follow-up very well structured, but we have some centers that, they cannot follow up these children. So what we want to do to PBSF project, and we know this is a very important pillar, and if you want to show that this actually works, it's important to follow up this population somehow. So what we were working right now, we're developing a new system, it's like technology, like an app that the families that received the PBSF assistance can be connected to us, and we are also having some partnerships with other follow-up clinics, and again trying to promote this follow-up in different ways. But this again is a big challenge, because one thing is, we are trying to do follow-up in a single clinic and build a well-structured program. The other thing is trying to build this in 30 different hospitals across the entire country. So this is a bit of a challenge.
There's another question. If the EEG is normal, but the baby has all the criteria to suggest HIV stage 2, are we not giving these babies hypothermia?
So that's a very good question as well. And I think this brings an important discussion. But if you follow most of international validated protocols, and even the NICHD criteria that we follow and use here in our centers, actually, if the baby has, you do the neurological exam, and if the baby has moderate or severe HIE, even if you do not see these abnormalities in the EEG, even though you're gonna provide cooling for this baby. So it's really, really important to be very well trained in the neurological exam for including babies in therapeutic hypothermia.
During the study, was there any observation of correlation of brain monitoring with amplitude integrated EEG and MRI changes for prognostic value?
Yes, very, very good question as well. And yes, actually we have even some publications in the literature, but more on. So what is really nice if when we have a baby with HIE, and what we look are two things. Basically, we look what we call some studies might call time to normal trace, which would be how many hours the baby needs, to recover at least this continuous normal voltage, and it's really important. And we have some systematic reviews and many studies stating, if the baby is receiving cooling and if he recovers to this normal trace between 48 up to 48 hours, he has a really, really high chance of having good neurological outcome. And there are many studies also correlating this with the findings. So if the baby has, sustained pathological background activity for 72 hours and or over this is usually very well correlated with MRI abnormalities. So this is quite good. And also, which is really important when we are doing EEG, seizure burden, but there you need the conventional EEG or the video EEG itself, but the higher seizure burden for this population, we know this is related to MRI abnormalities and also neurological impairment.
I know that this is beyond the scope of this project, but it would be useful to extend this telemonitoring concept to obstetric care and improve the monitoring of women in labor so that HIE can be prevented. Is there any idea which we can explore for tele-resuscitation to remotely assist clinicians during resuscitation?
That's an outstanding observation, and that's very, very true. So I think when we're dealing with hypoxia ischemic encephalopathy, birth asphyxia, it's very important, that there is very important improvements that needs to be done in prenatal care, during labor, just after birth in the NICU, and even in follow-up. So finding ways to use telemedicine to improve every single one of these pillars is truly, truly important. And even in the project that we are doing and working together with Imperial College London, the PREVENT study, you know, being able to use electronic partograms, intelligent auscultation, but other projects that, you know, could help use technology to assist labor would be really, really important. And also using telemedicine for education, for resuscitation itself, it's really important. So one major pillar, if you want to deal with HIE, is definitely the importance for preventing it. So yes, very, very good observation.
Ranjan sir, would you like to ask a few questions?
Yeah, I mean, I wanted to make a comment that the last question or last this thing which was asked is very sensible one. With the success of your project now, probably you should add some other things also which are related to neuroprotection, like the use of magnesium sulfate in preterm babies, and you know, even guide the hospitals regarding little bit of prevention. I know it's asking for too much. You are still establishing and strengthening your foothold in one field, but you should keep that in mind. Now, there are people interested in knowing what is the criteria for choosing a center in your project.
Yes. So in first place, again, I completely agree with you, Dr. Ranjan. Again, I think that's the path you want to move forward, you know. So again, looking at prevention and look at preterm population. So for the use of steroids, magnesium sulfate in this population, again, preventing neurological impairment even before the baby is born is really a major step, and we want to move forward this direction. So I'm sorry, the question you asked was about.
That is, what's the criteria for choosing a center in your project?
So actually, the major criteria for choosing the center, you want to, you know, of course, I think ideally every single niche would be able to provide at least, you know, brain monitoring and implementation of protocols. But what we try to find here in Brazil is actually the referral centers from each city, each state, you know, that concentrates the largest amount of babies being born in that region. And what we try to work also, and we do not have this very well established in Brazil, but we are working with projects, you know, to build a more robust transport system network. So what we want to find is centers again that might be referral centers and concentrate the expertise for this population and to provide both brain monitoring and also schooling. And we truly think this is the way, you know, we can concentrate better the investments that needs to be done.
There's another question which says, during the study, was there any observation of correlation of brain monitoring with amplitude EEG and MRI changes for prognostication?
Yes.
With prognostic value?
Yes. So we also do have a publication of a small study that published several years ago looking into this. But again, we have very, very nice data from the literature showing that the prolonged, you know, sustained abnormalities in background activity, especially if baby is receiving cooling, and he did not recover at least discontinuous or continuous normal voltage with over 48 or 72 hours of life, the chances of this baby developing neurological impairment, and also this is very well correlated with MRI findings, is really, really huge. And the other one that when we look at the EEG, especially for EEG, if the baby has a higher seizure burden, then the chances of this baby having abnormalities in MRI is quite huge.
Okay. There's another question which says, Brazil is an expensive country. How much cheaper is the monitoring and cooling system compared with Canada or Chile or Colombia?
That's quite a good question, because exactly I'm not sure what is exactly the cost
in those
of
countries.
brain monitoring in those countries. So I cannot answer this 100%. What I can say, it's probably much less expensive than in the high income countries as well. But what we try to do, we don't set up like a price or something like this. What we always try to do is a specific project for that center, and we always try to start the project somehow, you know, what's minimally necessary to make it feasible, and then with the learning experience curve, then we start, you know, implementing more monitors or things like this. But again, as one of the most important parts of this project relies on the education and implementing the protocols, even
That's
if
right.
we start with only one monitor, and you know, we make it really, really if not expensive, then we can also already do a difference.
Okay. I mean, have you had a lot of grants from your government or from international agencies? Have they been interested in this, Gabriel? I mean, if I can take the liberty of asking that question.
Yeah, no, you can definitely. And we are, I may say that in the early beginning, we had none, absolutely nothing. Actually, we had some people that believed that this might be important and then helped us with some investments, but we did not have anything from grants from the government itself. And now we are trying for it's and expanding itself. Then we are applying again, but we still are waiting for the answers.
Dr. Kadam, any more left?
I think, sir, we have covered majority of the questions, and we have also read a comment from Dr. Gautam Suresh regarding tele-resuscitation. Well, Dr. Gabriel, I had one question. In your journey over the last 4 years, when you started, what were the difficulties and how you have overcome? Because if you ask any NICU in the country that you need to get a machine for amplitude integrated machine, and the cost is something like 14 or 15 lakh rupees. It's a huge amount of money, and then that actually repels the clinicians in terms of prioritizing the expenses and revenue in buying such an expensive bit of machine. So
Yeah.
are there any way forward or in getting economical or a cheaper brain monitoring so that it can be implemented in a much wider scale in the country or all over the world in the LMIC without compromising the quality?
Yeah, so that's really a great question, and actually these are the barriers that I may say that I face every single day during my last 4 or 5 years. So again, what are the main barrier? Of course, you know, during my presentation I said, oh, I got this brilliant idea, why should not implement this for everyone? I came direct at that time to government. You know, we don't have much money, it's difficult to implement something like this. So definitely the limitation of resources, I may say, is the largest barrier. And it's tough because, you know, when you come to the clinicians, when you come to, you know, the physicians, the nursing staff, when you go to conferences and you show that it's important to provide adequate care for these infants, all they say, it's really easy to convince the clinicians that, you know, this is something important. But the big thing and the big step is convincing actually, you know, the directors of the hospital and even, you know, the public centers say, okay, but why should I invest on this? And again, I think that the beauty of this kind of project is this allows us to implement these protocols in a lower cost model. Why this is lower cost model? Because again, using telemedicine allows us to concentrate the expertise, the information, the resources. As more centers get connected to the network, it usually allows, you know, lower costs for the entire model, which is really nice. Also, what we faced and we use it again is that implementation of the model that the center do not require to buy the equipment because they don't want to, you know, do this initial investment, which is quite huge, and we know these equipments are really expensive. So we try to dilute this in years and years of, you know, of partnership with the centers. But I may say that, you know, also that makes a big difference and allow us, you know, to get through these barriers is the commitment of an entire team that truly believes in the importance and the possibility of growth of this project and organization itself. So this requires lots of persistence and hard work, because it's never really easy, you know, to start a new center, convince people that they need to invest on this. And again, the way to convince the directors of the hostel, the people who actually have the possibility to implement this in their centers, is trying to show that the economic burden is devastating. So if they invest in here, this makes lots of sense, not only because it's important for the better care, because they are also, you know, saving resources, which is also important.
Thank you so much. Yes, sir.
Any more questions? Shall we?
So one last question.
Yeah.
Can this novel concept be upscaled to other areas of neonatal care apart from neonatal neurology?
Yes, I completely think so. You know, again, as future directions, we are thinking, you know, using these specialized assistants with consultations from, you know, from cardiologists, genetics, infectious disease teams, especially for centers who are not able to have these specialists in their own centers. So why should not you use telemedicine to aid the center somehow? And again, a lower cost model. I think this definitely can scale to other areas of neonatal care.
Fantastic. Sir, we don't have any more questions. Ranjan sir, would you like to make any comment?
I would just like to say that it's amazing. What you have done is amazing, Dr. Gabriel. Your presentation has been brilliant. Your idea is very innovative, and your progress which you have made in 4 to 5 years is awesome. So I am sure this is all due to your commitment, dedication, and your hard work. And we really wish you all the best. And lot of young minds must have thought of lot of ideas listening to your presentation. See, they say that invention is the mother of necessity. So in countries like India, I would say cost-effective inventions and innovations will be the mother and grandmother of all necessities. So we need in our country cost-effective interventions. We need in our country, you know, the telemedicine to be used very optimally and achieve what we aspire to achieve. So congratulations once again, and thanks for sharing your presentation experience and your agonies and ecstasies during the journey of 4 to 5 years.
Dr. Gabriel, it was wonderful. I mean, your original work, your hard work, you know, it inspires, I'm sure, a lot of neonatologists in our country and outside. It has been an inspiring experience, and I'm sure this would definitely help younger generation to do many more things in days to come. Your presentation was excellent, and there's one, I think, we wish you all Merry Christmas. And there's one question last, I think, do you provide clinical advice for functional echo, PPHN, and coagulopathy during cooling?
How are you?
Yeah. So in first place, I'd like to say thank you so much, Dr. Ranjan. Thanks so much, Dr. Sandeep. This was an amazing session. I feel really honored to be part of this webinar series, which is fantastic. As Dr. Ranjan says, you know, the webinar series itself is becoming legendary. So again, thank you so much. And I think one thing that, you know, 2020 teached us all that we can collaborate with people across the entire world. You know, this is actually feasible, and I truly think it's really important, you know, to collaborate, to share experiences, and we are definitely 100% open to help. I think the knowledge itself, it just works if you can share with people and improve science and help in the end of the day our babies. That is what all we want to do. So again, thank you so much. I feel honored to be part of this session today. And just to answer the last question, so we do not, especially in
PPHN.
Yes, so Actually, we help, conducting the clinical case itself. So if you have a severe and critically ill baby, so yes, we are gonna help for managing PPHN, coagulopathy during cooling. So definitely, and actually this becomes a part of our protocol, for management of these babies with severe HIE or during cooling. So yes, we definitely do the training for this and help and lively. So many times, people can call our staff and let's discuss the protocol together. Let's discuss this case and think what should we do. Yes, so this is important as well.
Yeah. So thank you very much. I'm sure we go home with a lot of knowledge. We go home with a lot of ideas that you have given us. I'm sure they would help our babies in days to come. Thank you very much. And with this, I will hand over the proceedings to Dr. Manoj. We would also like to thank the organizing committee for inviting us to moderate this excellent session. Over to you, Dr. Manoj.
Yeah, I would like to say thank you so much for Dr. Manoj as well. Thank you so much for the invitation.
And their team.
Thank you, everyone. It's as we also said, all good things need to come to an end. It's time to wind up today's session, so we'll make it very brief. Let me, on behalf of the organizing team, thank Dr. Gabriel for doing a wonderful talk, and Dr. Ranjan Pejawar and Dr. Sandeep Kadam for moderating this session so well. We are already short past time. Before we wind up, let me also thank the respected delegates. We are truly honored to have you with us, and it's a honor. It's a true honor. Today was the 18th and the last webinar into 2020. We begin 2021 with a practical issue. Our 19th webinar will be on 5th January on what dogmas in neonatology are in need for change. I would humbly invite all of you to kindly join us for that as well. With that, we say goodbye and see you next year, 2021. Thank you so much.
Thank you. Goodbye, Manoj.
Thank you and Happy New Year.
Thank you.